fellows platform. And this is hosted by the Gastroenterology Foundation, along with Project ECHO, which you now know about. And we run every fortnight on a Monday at 6 o'clock. The chat will be open for questions, but I'm also happy for people to just put up their hands after the presentation to ask questions. So today, Shaun Temmers is going to talk to us on the pathology, well, the anatomy and physiology of the small bowel. So last year, what we did was that we all gut in one session, which was quite a lot to cover, but also I think when we got to the specific areas, you might have forgotten that. So this to separate it so that in the ensuing sessions, you can relate it better to this session. So obviously it's a difficult topic, a lot of information to take in, but really the idea is to set the scene and just to remind you of the importance of the functioning of the small bowel, and then I think it will make it a bit easier when we do pathology. So Shaun, please take it away. Questions out.
Thank you, Prof. Just share.
Perfect. We can see it.
You can see?
Thank you.
Okay.
Yes, we can see it.
Okay. Yeah, so evening, everyone. Our topic, as has been indicated, is the anatomy and physiology of the small bowel. Important aspects are that you should take away with you. So the outline of the talk will cover embryology and developmental aspects of importance. We'll go over the macroscopic and microscopic anatomy of the small bowel. We look at some histological aspects of the various segments of bowel, and then we'll talk a little bit about physiology, specifically gut motility, small bowel motility, and its absorptive function. You will notice that once we get to certain sections that it's quite a large volume of information to try and get across. So we'll go over some of them, but there'll be a lot of reading that will be required post. So we start with the anatomy. So this slide illustrates a timeline of embryology, and gastrulation occurs roughly at about 3 weeks post-conception. Now, the gut is made up of elements of both the endo, ecto, and mesoderm, but the majority of the gastrointestinal tract epithelium is made up predominantly from the endoderm. So gastrulation occurs at around 3 weeks, and the primitive gut remains an open tube. The gut tube actually closes about a week later, and then intestinal loops start beginning to form. At this stage during embryological development, the gut's orientation is still very much a single linear tube from oral to anal. Then 2 weeks later, about week 7 of the embryological development, herniation of the gut loops occur. And this happens because the intestinal loops actually grow much faster than what the abdominal cavity can accommodate. So it herniates outside of the abdominal cavity, and it remains out there while it keeps on elongating and maturing. Initially, when it herniates out, there's clockwise rotation of the gut on a single mesentery, and then there's counterclockwise rotation that occurs at roughly about 8 weeks. Once counterclockwise rotation of this the mesentery has occurred, the gut then slowly starts herniating back into the body at about 9 weeks, 4 weeks after it initially herniated out, to return back into the body. Once it's back into the abdominal cavity that can now accommodate it, a second rotation occurs, and this allows then for the gut to be fixed in its current orientation that we see in adult life. The first villi start to develop at around 11 weeks, and it is then populated with intestinal enzymes about a week later. The enteric nervous system is completely formed by 13 weeks of gestation, and it matures throughout early neonatal life to have a completely matured gut at around 6 months of age. The first signs of lymphatic tissue, the Peyer's patches, can be seen at about 20 weeks, and most of those lymphatic cells are predominantly formed within the gut wall, and they remain there for the entirety of both childhood and adult life. When we take a closer look at herniation and the rotation of the gut, we'll follow diagrams through A, B, C, D, and E, as alluded to earlier. First, the primitive gut herniates out attached to its mesentery. So there's a first 90-degree rotation that occurs as it herniates out of the abdominal cavity. This allows for elongation of the jejunal loops to occur, and the appendix and cecal pole is then rotated onto itself. It then gets rotated a further 180 degrees just before it reherniates back into the gut at about 9 weeks. Once it's back into the abdominal cavity, that 180-degree pole allows for the cecum now to be positioned, as you can see in diagram D, to be in the right upper quadrant. It is then pushed inferiorly, and as it's being pushed inferiorly, it's fixed to the right lower quadrant, and simultaneously the jejunal loops is fixed to the left posterior part of the abdominal wall. But the remainder, jejunum, ileum, and sigmoid remains free and loosely attached to the mesentery. And this gives you this orientation that we see in adulthood with the cecum and with the sigmoid and rectum located on the left-hand side, and the cecum and ileal loops located and fixed in the right lower part of the abdomen. Because of the intricacies with regards to ediogenesis that occurs, there's multiple steps where significant abnormalities can occur. This table illustrates the important abnormalities that we see. So first, there can be abnormalities of the abdominal wall, of which an amphilucio gastrocchesis are the most commonest. There can be abnormalities of the vitelline duct, of which a Meckel's diverticulum is by far the most commonest abnormality that we see there. There can be malrotations. The rotations can either be non-rotated, reverse, or completely malrotated. There can be duplications. Atresia and stenosis commonly seen within the duodenal and jejunal loops, and then abnormalities of the enteric nervous system, of which Hirschsprung's disease is the prototype disease there. Then there's diseases that can occur due to abnormalities that occur post the development of villi, as well as its enzymes. And here you can have either microvillus inclusion diseases, or you can have various deficiencies in enzymes or channelopathies that would occur. And this normally occurs at about week 12 of gestation. When we look at a macroscopic anatomy of the small intestine, it's a hollow tube. It's about 6 to 7 meters in length, and it begins at the pylorus and ends at the ileocecal valve. Now, the diagram labeled B shows the 3 constriction points of the small bowel. So the first fixed point of the small bowel is at the pylorus, where it is fixed to the posterior abdomen, to the anterior abdominal wall. The duodenum is then fixed as it exits the retroperitoneum back into the anterior abdomen at the transition between duodenum and jejunum, and this is known as the ligament of Treitz, which is a folded peritoneal loop. And then the last part of fixation is at the invagination of the ileum into the cecum, where the distal part of the gut is fixated by the superior and inferior cecal ligaments. The rest of the small intestine is loose within the abdomen with a very, very thin mesentery that fixes it to the posterior wall. The proximal portion of that small bowel is the duodenum and can be divided into 4 sections. The first part is the only part that's not retroperitoneum, and it's connected to the liver and parts of the anterior abdomen via a thin ligament known as the hepatoduodenal ligament. It then transverses retroperitoneally, where it wraps around the head of the pancreas and the descending portion is the site for the major ampulla. It then returns to the abdominal cavity at around L2, and then it's fixed by this cross-folding of mesentery, the suspensory ligament, which you know as a ligament of threads, important landmark, as alluded to in earlier talks, for the site of differentiating presence of GI bleeds. This point also marks the transition of duodenum to jejunum. Now, endoscopically, what does it look like? And if we look at image number 9, that's the duodenal bulb. And you can see that there's a very tight angle that we've all come across, that we have learned to maneuver around. As you maneuver around, you start seeing the rings of the small intestine, and the first linear fold of the intestine that you see is the major ampulla. These are all quality assurance landmarks that we all look for when we do upper endoscopy regarding, especially entering the small intestine. The jejunum and ileum is described together because there's no clear transition point between what is actually jejunum and what is ileum, but there are subtle differences between the two segments of the bowel itself. The jejunal portion of the small intestine resides predominantly in the left upper quadrant. It's free and it's attached to its mesentery. It's about 2.5 meters in length, and it's suspended to the posterior wall of the abdominal cavity. Closer look at its luminous surface. It reveals folded circular and submucosal folds, and this allows for increase in the surface area. These folds are known as plia circularis, and as you move anally along the tube, the presence of the plica circularis decreases until you reach the distal terminal ileum, where they are completely absent. Mucosal folds within the jejunum is also much thicker than that is found within the ileum. And as you move anally, the presence of lymphoid patches and lymphoid tissues increases, and there's a large conglomerate of these patches or lymphoid tissue that is found in the ileum, and simply referred to as Peyer's patches. The ileum then terminates where it invaginates into the cecum, and it's fixed there with its superior and inferior cecal ligaments. The ileocecal valve itself is two semilunar lips that invaginates or protrudes into the cecum, which I'll show you a bit later. So if you look at the images in this particular endoscopic diagram, we start from right to left. Right is the cecal pole. You can see the appendix over there, and you can see the ileocecal valve here with these two thick folded ileo folds. The image in the center is an open ileocecal valve. It's also more commonly seen as swelled colons. And then the last image is intubation of the terminal ileum, as you can see the villi surface of the terminal ileum. Again, quality assurance images at endoscopy that we all are aware of. The histological layers of the small intestine consists of 4 layers: the mucosa, a submucosa, muscularis propria, and a serosa or adventitia. The diagrams at the top show you the close relationship to these layers, with the muscularis propria containing 2 circular muscles, and the mucosal epithelium containing microvilli or villi that's present, as shown in the diagrams above. When we take a closer look at the mucosa, it's further divided into 3 distinct layers, consist of an epithelium, a lamina propria, and a muscularis mucosae. The predominant cell there is an absorptive cell, which is known as the enterocyte, and each enterocyte contains more than 3,000 microvilli. They are organized in a cryptovillous axis, and they constantly proliferate and differentiate, with the stem cells located at the base of the crypt, as you can see in this diagram, and they migrate to the apical pole. This allows for 7 distinct cell types to occur within the epithelial layer, and these enterocytes are held together by zonocludens, which holds them tightly together. The lamina propria provides a connective tissue base, and it's the presence of mast cells and lymphocytes, as you can see as illustrated in the diagram over here. Muscularis mucosa is a very thin layer of smooth muscle that plays a small minor role with regards to peristaltic movement of the small intestine. Those different cell types are summarized in this table. First, you can get our enterocytes. They are tall columnar cells with microvilli at the apical site, and it's the predominant cell of the epithelium. There's Paneth cells. They are large pyramidal cells. They've got eosinophilic granules at the apical end. They allow for defense against bacteria and secrete lysosomes and defensins. They're found at the base of the crypts or the crypts of lubricant. Enteroendocrine cells are found within the crypts. They contain granules and very close to the base, and they help regulate intestinal activity. It contains certain hormones such as cholecystokinin and secretin. Your goblet cells, they're very large granular cells at the apical surface. They're mucin secreting cells, and they allow for cytoprotective effect. They're found throughout the small intestine, but they're in very high concentration in the jejunum and the ileum. Tuft cells has microfilaments that are connected to this very long villi, and again, they're found throughout the jejunum and the ileum. M cells are antigen sampling cells. They are epithelial cells, and they lack the typical brush border that we see. They have many vesicles, and they overlie the base patches in the distal terminal ileum. Submucosa is a connective tissue layer that contains mast cells and fibroblasts. It aids in the absorptive function of the mucosa. There's a collection of ganglions that can be found within the submucosa, known as the Mason's submucosal plexus, and this helps coordinate peristaltic movement of the small intestine. As alluded to before, the muscularis propria contains two muscle layers, a circular muscle layer and a longitudinal muscle layer, and embedded in between them is the second neural plexus, known as the mesenteric plexus, that you can find all the way along the small intestine. Serosa is just a thin layer of residual mesothelial cells, and it has and gives a loose connective tissue structure to the intestine. This particular slide illustrates the difference in composition of duodenum, jejunum, and ileum. And if you look at the first image, you can see that lymphoid tissues, so this is a high power field, and lymphoid tissues are on this on this PAS stain, it stained darker, and they are higher in concentration in the ileum as compared to the duodenum and the jejunum. The duodenum also has these longer villi and long villi to crypt ratios with increase in brush borders. But as you look closer to these slides, you can see that there's little goblet cells, and they occur predominantly in the jejunum. You do find them in the ileum, but they're very scanty within the duodenum in itself. The image to the right just gives you a closer representation at a high power field of the closer relationship between the four layers of the intestine. Intestinal blood supply. It has a single blood supply from oxygenated blood that arises from the superior mesenteric artery, and this supplies the jejunal and ileal loops, and the duodenum, however, has a secondary blood supply and gets blood from a branch from the gastroduodenal artery, which in itself is a branch from the hepatic artery, which is a branch from the celiac trunk. Venous drainage is via the superior mesenteric vein, and the superior mesenteric vein joins the splenic vein, and this forms the portal system and drains into the liver and then empties out into the IVC. Each villus contains a single lacteal, and this lacteal will then drain into a mesenteric lymph node, and this is located all along the SMA. And this drains into the thoracic duct on the left, where it enters the superior vena cava at the subclavian on the left. The largest number of immune cells are found within the intestine, and they are made up of macrophages and monocytes. They have their origin within the intestinal wall, as alluded to during the embryogenesis slide. Dendritic cells migrate from the bone marrow and aid the macrophages in their functioning. There's a close relationship between the macrophages and the dendritic cells. And the diagram to the right illustrates various surface proteins that respond to different stimuli and its regulation with regards to triggers within the intestinal lumen. There's three distinct types of macrophages that you can find. There's those that are found within the lamina propria, those that are found within the pes patches, and then the macrophages that are found deep within the muscularis mucosa. Their role is both as antigen presenting, but also to allow for immune tolerance to some of the exposed antigens, whether it be from food particles or nutrient particles or from biological particles from either bacteria or broken up particles from eukaryotic cells. They're found in lymphoid follicles, specific specialized lymphoid tissue that can be found in the distal part of the terminal ileum, and those follicles are referred to as pes patches. Now, this diagram on the right illustrates a complex interaction of innervation of the intestinal nervous system. There is communication from parasympathetic, which is predominantly via the vagus nerve, cross-communication via the nodose ganglion, and interaction between the enteric nervous system as well as the muscularis from vagal input. However, there's a large network of parasympathetic, sympathetic input of the sympathetic innervation occurs from the trunks T5 to 11. These fibers interact with the spinal cord and prevertebral ganglions, and they respond to various stimuli, sympathetic stimuli from both the gut lumen itself, the muscularis, the muscular layer, as well as from supratentorial input. Although this complex network of interaction of the extrinsic nervous innervation is present, it's not absolutely required with regards to the functioning of the day-to-day functioning of the enteric nervous system itself. That enteric nervous system, you can see, is actually summarized in the communication between nerve endings of the enteric nervous system, specialized cells known as interstitial cells of Fajal, and communication between the muscularis layer itself. The nerve cell bodies are both present within the wall of the small intestine, and the processes are embedded within that gut, in the gut itself. There's around somewhere between 200 and 600 million neurons that can be found there. All three classes of neurons are present: motor neurons, interneurons, and primitive IPAMs can also be seen within the within that network. The IPAMs are thought to be communicating signaling between both the motor and sensory neurons within the intestinal wall. These neurons are intimately involved in motility, secretion, regulation of blood flow, and the two major complexes, enteric complexes that you find is the enteric complex, which is solely involved with motor innervation, and the submucosal plexus allows for regulation of blood flow, as well as it plays a endonephrocrine function. Motility is aided by the presence of smooth muscles, and these circular smooth muscles have a very unique characteristic. They are contractions that are driven by calcium influx, and the pool of calcium is found within the cytoplasmic reticulum. Once calcium influx occurs, there's multiple intercellular pathways that allows for contraction of this sort of cross-linkage that are quite similar to actin myosin cross-linkage as seen in striated muscle, but there's no striated muscle within the small intestine. These contractions that occur between 11 and 12 minutes from the jejunal lobes, and it decreases as you move anally to the terminal island to about 7 to 8 minutes. Short spikes occurs, and once the contraction action potential is initiated, that contraction is then propagated in a circular fashion from anal to orally. Initiator cells that allows for this contractive complex and calcium influx to occur is known as the interstitial cells of Kajal. They're specialized cells, and they are found in close proximity to the myocyte as well as the nerve endings within that muscularis propria cell layer. Two roles they have is that to be pacemaker cells of the gut. They transduce both inhibitory and excitatory signals, and you find them in three functional groups. They're either interstitial cells of Kajal in the deep muscularis propria, the intermuscular cells, or those that are in close connection to the myocyte itself. The excitatory input is via muscarinic 2 and M2 and 3 receptor activation, and inhibitory neurons are mediated via VIP and nitric oxide stimulation. This movement and automacy of the gut allows for peristalsis, and peristalsis is a progressive contractile activity that runs in an aberrant fashion. In other words, there's contraction of a portion of the intestine, and it moves the bolus forward in one singular direction. So there's contraction and distal dilatation, and this propagates movement of the bolus. It's coordinated entirely by the enteric nervous system, and it can be initiated by both mechanical, in other words, stretch or contractive forces, or chemical stimuli. But it also has a sensory and a motor input. It's thought to be mediated by IPAM activity, but this has not been well described. Reverse peristalsis does exist, and it occurs, and it's thought to be the mechanism of emesis that we see in patients. Modified version of movement or motility is the interdigestive motor complex. This is the means by which the small bowel propagates boluses of food. So the migrating motor complex is divided into three phases. Phase 1 is a croissant phase, and this lasts between 45 minutes to 2 hours. This phase is thought to be when most of the absorption occurs within the small intestine. This allows for maximal contact time with the villi and the epithelial surface of the intestine. The next two phases, phase 2, which is a chaotic phase, lasts between 20 and 30 minutes, and it's characterized by irregular contractions. There's fluctuations with the amplitude, so you can get very low amplitude and very high amplitude contractions, and sometimes also audible contractions can be heard. Phase 3 is a more regular amplitude contraction. It lasts between 5 and 7 minutes, and the amplitude of these contractions are higher. So you go from this chaotic phase to a more regular phase, and then a croissant phase. And this propagates the movement of the content within the intestine. Now, this transit can be affected by a host of things, distension being one of them, but the osmolality of the fluid itself, pH itself, and the presence of these active substances can affect the transit within the small intestine. You can measure this contractile activity within the bowel, and there's various tools for measuring small bowel motility. However, manometry with channel-based sensory catheters gives you a direct measurement of contractile forces. Issue with it is that there's a limitation to the amount of channels that you can have, the length of the actual device, and you can see in the graph below, this is a a report from a small intestinal manometry where you can see the probe within the distal duodenum, and it's sort of in that second phase of the MMC where there's chaotic contractions, but it's small and high amplitude. MRI gives you the best, functional MRI gives you the best modality with regards to looking at small bowel motility, because you can in real time see and measure both movement and contraction of the bowel. It's non-invasive, lacks radiation. The problem with it is expertise within doing the investigation, the cost, and the general availability. In all, testing for motility is not really available, and it should be covered in one of the topics later in the curriculum. Regarding the absorption, most chemical absorption occurs within the small intestine. The diagram to the right of the screen shows where most things are absorbed. So water and electrolytes get absorbed in the proximal small intestine, also within the rest of the intestine and the large bowel. Most of your fats, carbohydrates, and proteins are absorbed within your jejunal loops. Your micronutrients are absorbed within the jejunum, and the terminal ileum actually only allows for absorption of B12 and recycling of bile acids. Now, if we look at lipids, most lipids are absorbed in the upper 2/3 of the jejunum. It's a multi-step process of which we won't cover all of it in this particular talk, but the important parts of that multi-step process is that most lipolysis occurs within the small bowel. So pancreatic lipases enter the gut via the pancreatic duct. Bile salt serves as an emulsifier for these fats. They're then transported by micelles by active transportation across the epithelial surface into the enterocyte. They are absorbed within the enterocyte via fatty acid transport proteins. Then they are packaged in the enterocyte together with these fatty acid binding proteins and to form chylomicrons. The chylomicrons are then transported into the lacteals, and the lacteals makes its way into the systemic circulation. Carbohydrate absorption is another multi-step process, but the important parts of that process is that most starches are hydrolyzed within the lumen via pancreatic amylases. Yes, oral and gastric amylases does play a very small role, but the major role is played by pancreatic amylases. The products then go further hydrolysis via apical border carbohydrases, and the table summarizes the brush border carbohydrases that are present on the villi surfaces. So it shows this substrate and its major end product. So maltase cleaves alpha-1,4 oligosaccharides, lactose gets cleaved by lactase, sucrose by sucrase, and then the end products are either glucose, galactose, or fructose. So once you have your glucose, galactose, or fructose, they enter the enterocyte either via active transportation via your sodium glutatransporter 1, which is galactose and glucose, or fructose via GLUT5 transporters. Once they're all within the enterocyte, they are packaged and transported into the capillary at the basolateral membrane via GLUT2 to enter circulation for use and further processing. Proteins are degraded to small peptides and amino acids before they can be absorbed. Pepsin activity allows for breakdown of large proteins, but it's inactivated within the small bowel. Pancreatic proteolytic enzymes continues this process. The table shows you the proteolytic enzymes and their function, where trypsin cleaves bonds at lysine and arginine. Elastase cleaves your aliphatic amino acid bonds. And then your carpeptidases A and B cleaves either the amino acid ends or terminal ends of the peptides or the lysine ends of the peptides. Once the smaller amino acids are liberated from your polypeptides, they are then transported into the enterocyte again via active transport transportation, and then for further processing to smaller amino acid compounds within the liver. Your micronutrients, folate is absorbed with iron in the duodenum and the upper jejunum. Folate is further hydrolyzed by glutamate carboxylase 2 at the brush border. Vitamin B12 has an interesting absorptive process. As it enters the gastric lumen, it binds to an R protein. It also binds to intrinsic factor within the small intestinal lumen. Within the small intestinal lumen, however, by the activity of proteolytic enzymes, the R protein is degraded and it liberates this B12 intrinsic factor complex. This then binds to AML receptors within the terminal ileum and it's actively absorbed into the circulation. Vitamin K has two forms of absorption that can occur, and it depends on the metabolism on the vitamin K itself. So vitamin K1 can be dependent on bile salt absorption, and it's carrier mediated with active diffusion. K2 is actively converted by intestinal bacteria, and that can get absorbed passively across the terminal ileal enterocyte border. About 9 liters of water is delivered to the gastrointestinal tract every single day. 7 of that 9 liters is absorbed by the small bowel, which makes the small bowel highly efficient with regards to absorbing water. For all that efficiency, the exact mechanism of absorption is not well understood. There's presence of aquaporins, there's osmotic gradients that are created by solute content, but none of these have been clearly described as a mechanism for the absorption of free water from the small intestine. But it's very efficient at absorbing water. In conclusion, a concise understanding of the mechanism of small intestinal motility, its absorptive function, its microenvironment is essential for the management of a vast array of gastrointestinal disorders. The small intestine facilitates digestion and absorption of nutrients as well as water. It continuously replenishes its epithelial surface. It has both an immune system and a brain of its own. These are just a few of the references used in preparation of this talk, and thank you for your time and listening. And I hope you're not asleep.
No, hardly. Can you hear me?
I can hear you.
Okay. So thank you so much, Shaun. So Shaun sent me the presentation last week, and I thought it was so well put together and very nicely laid out with a topic that is really quite difficult. And so I thoroughly enjoyed it on Friday, I think, when I went through it. And I found it even more so today. So yes, very difficult topic, but you've done such an excellent job of packaging it that I found it interesting, and I think it's a good reminder of our basic sciences, which is important. And I think the lectures that follow will make much more sense, in terms of nutrition, fluid management with high output stomas, with short bowel syndrome, basically everything that Shaun has so well gone through. So I couldn't find that much else to add to your presentation, but I thought some fun facts over the weekend, some of which I knew, but some of which I didn't. So do you know where the term jejunum comes from?
No idea. I can't say that word.
So apparently it's a Greek term. It means jejunos, which stands for fasting. And apparently what they found was that when somebody dies, relative to the duodenum and the ileum, the jejunum, because of its massive peristaltic activity, tends to empty relatively quickly. And in fact, if you think about even all the chyme or chyme, I don't know how you guys pronounce it, from the stomach, the main aim really of the jejunum is so that that can transit quite quickly in the jejunum, because most of the absorption, in fact, of nutrients and stuff, yes, it starts in the jejunum, but it actually happens in the TI because it's a longer segment and so forth. So it actually empties quite quickly because of the intense peristaltic activity. So they called it fasted, which translates to jejunous. And other than what you described, are the differences between the duodenum and the jejunum and the ileum. What other difference do you think the duodenum has in terms of cells that are there that are not in the jejunum and are not in the terminal ileum? So in the table of yours where you listed all of the cells, where they come from and what they do, there's a type of cell that was missing.
Yeah, there's a missing
Probably
cell.
know it, but you didn't think about it.
Brummer's gland.
Yeah, Brunner's glands. So what do Brunner's glands do? So they're only found in the duodenum, and their specific function is what?
To confuse people to think that they are polyps. I don't.
So basically they're there to produce a lot of mucosa to protect the contents, the acidic contents that are coming from the stomach, because everything just gets dumped into the cap and the first part of the duodenum. Okay. So they secrete alkaline mucin, which then counteracts the very, very heavy acidic stomach contents that are entering the duodenum. So that is basically their role, and you don't find them anywhere else. And in that table of yours, I liked it. Just don't forget that, like every other part of our body, you start off with stem cells that start in the crypt ubiquum, and then they differentiate into enterocytes, endocrine cells, Paneth cells, Rana, etc., etc. So yeah, don't forget that it basically all starts with the stem cells, which then differentiate into the different types of cells. And then I found something interesting, which I didn't know, that another type of cell, and this is a paper that I found in Nutrients in 2021, are what they call the taste receptor cells. So they say they are like the cells that you find on your tongue, and these you find in the duodenum and jejunum, and they, just like the tongue, they express taste receptors, and they can detect sweet, umami, which is sort of a savory taste, and bitter taste in the luminal contents. And they think that this might play a role in nutrient sensing, as well as the gut-brain axis interaction. So I think maybe in time we'll find this described more and more, but I didn't know that there are taste receptor cells in the duodenum and the jejunum. And then, yeah, has anybody else heard about these cells? Viji? None? I thought you were on as well.
Right. Good afternoon, Prof. Mesh.
Good evening.
Good evening, yes.
Maybe in Bloemfontein it's afternoon. I don't know.
No, it's late actually, and it's cold. Okay. No, I haven't heard about any.
I always know this basic science stuff. Have you heard of these cells?
No. Lately, I haven't heard about anything now.
Okay.
No, I'm sorry, I haven't heard about it. It's news to me. It's news to me, but it's good news.
It's good news. And then, Shaun, just to remind everybody that remember that IgA is produced in the intestine, and as you said, the immune activity happens mainly in the lamina propria, and of course much more in the Peyer's patches in the TI. And the difference between this subgroup of immunoglobulins compared to the others, so I activate, somebody's coming in now, maybe they're late, does not activate a complement. And so it doesn't work through oxidization and destruction of the infectious agents, which is in sharp contrast to the other immunoglobulins. So I thought that was also a bit interesting. And then everything else you've mentioned, and basically if you look at the jejunum compared to the ileum, it's a little bit redder. And if you do an enteroscopy, you actually will notice that it's a lot more redder because it has a lot more vascular supply. And it is thicker relative to the duodenum and to the ileum. So in terms of trying to determine how your depth of insertion with enteroscope, apart from the pushing in and pulling out method of guesstimating, you can tell when you are deep in the jejunum when you do a double balloon. Yeah, I think those are only the comments, just additional stuff. And don't forget also that the enterocytes, they renew themselves quite rapidly every 3 to 5 days. And whenever you have any condition, infectious, inflammatory, neoplastic, radiation, whatever the damage is, you lose the disaccharidases at the brush border. And so you could have a patient with celiac disease, but they may also have lactose intolerance. cause of damage to the brush border and the absorption that takes place there. But as I say, I really enjoyed it. I thought it was really, really nicely done. I don't think I could have done it better myself. Are there any comments or questions from anyone? Please put it in the chat, or better still, put on your microphone, tell us who you are and where you're from, and ask your question. Anyone else? Looks like you were very comprehensive.
Just a very brief comment. Yeah, I thought that was quite comprehensive. Hard to actually recall most of the stuff. Like I remember bits and pieces here and there, but I think it's also important for the guys, for the fellows to remember to apply some of these things. So some of the conditions that we see, the only way you can sometimes recall some of this physiology and basic anatomy is by remembering some of the illnesses and the pathology, and then recall the physiology. It is quite hard to keep all of this in your head all of the time. The only other thing I want to ask Mashiko is, as part of the physiology of the small bowel, I think, of course, not sure exactly where it fits in, but it has been an emerging role for years now, is the organisms within the lumen of the small bowel. And that's probably something we haven't spoken about, unless, Shaun, I did fall asleep during that time.
I purposely let it out, Vijay.
Okay, good. But I think we do know that it probably plays a role in everything, in all of the physiology as well, or it may be playing a significant role. So when we talk about physiology, I think we are reaching that point where part of that conversation also includes the impact of the like a small bowel flora or like microbiota.
Thanks, G. You make a very important point. Unfortunately, I missed the session at Sages where we asked Professor Brink to talk about the small bowel microbiome, because we always talk about the large bowel, and that makes sense because you have bacteria there. And I guess I don't know that much about the small bowel microbiome. I know a little bit about the gastric microbiota in how H. pylori basically a very, very important point. And I think we're probably going to see more and more about the small bowel and its role. Another thing that I've learned just along the way is there's a difference between luminal microbiome and the mucosal microbiome. So if you took a stool and you compared it to a biopsy sample, there would be differences between the two microbiota. So I think it's a fascinating area of study, and you're quite right. I think its relevance not just in GIT and liver disorders, but in all disorders, neurological, cardiovascular, etc., is increasing. So thank you for that. And the comment about relating the physiology and anatomy to clinical conditions is important. I mean, I was just reminded as he was talking about SMA syndrome, in anorexic, very, very thin people. And if you don't think about that, you'll never make that diagnosis, So very, very key, Vijay. Thank you for that. Any other questions or comments? All right. Well, it's a winter evening, and so if there's nobody else, if there is just a holler, as they say, but yeah, if there's nothing else, I first want to start by congratulating our candidates. So we had 5 candidates writing the certificate exam, and all of them passed. But the guys did so well. I was moderating, and I was just so impressed by all of them, and really, really proud of them and their achievements. So I saw that Ram Makan from Bloemfontein and Desiree Moodley are on the call. Congratulations, guys. I think you really thoroughly deserve your achievements. And then there's Hilmi and Francis Innocent, who are here. I said to them, I'm not going to be monitoring the attendance list to see if they're attending or not tonight. I think the results were released tonight. And then the other candidate is Badrelin Yusuf. I think it's Yusuf. I hope I'm correct. So congratulations, guys. I think you've done just stunningly well, and your knowledge and maturity that you showed in that exam was really wonderful. So wonderful, and I was just so happy today. So thank you for that. Back to the business of the day. I want to thank Shaun for his hard work and really just beautiful slides. Really well done. And then I want to thank Karen and Cheryl, who help us obviously with the administration and running the program in the background. Of course, we thank the Gastroenterology Foundation of South Africa, as well as the sponsors of the Gastro Foundation. So in 2 weeks' time, it's going to be small bowel intestinal bleeding. So that's going to be presented by Simon, and the facilitator is going to be Shiraz Gabriel at Tygerberg. So with that, I see there's comments here. I think it's just congratulatory messages. Yeah, thank you so much, everybody. Really appreciate it. See you in 2 weeks' time.
Thank you.
Take care. Well done.